Super. Well, good afternoon, everyone. Thanks for being here today. We're going to have a presentation today on the issues of implementation science and operations research. I'm going to try to work my way through the technology to see if I can get this together. But let me just first start out by saying that implementation science research and research has got a lot of different definitions, and many people interpret them to be the exact same thing. So one of the problems is that the one overarching definition says that the scientific study of methods to promote the integration of research findings and evidence-based interventions into healthcare policy and practice to really improve quality and the effectiveness of healthcare and healthcare delivery. Now, the other sorts of terms that are oftentimes but incorrectly interchangeably is that some people use the term operations research or operational research. Other people might use the word implementation research or implementation science, and then others may use the term health services research. What I'm going to try to do as part of this presentation is to sort of disentangle that to really provide some sort of clarity around what these various different things mean. Now, just to clarify what implementation science and operations research is not, is that it is not dissemination. And dissemination is where you will take an intervention and you'll expand it into the clinic. For instance, you might want to, or the hospital, you might expand something like putting hypertension treatment using a diuretic to normalize blood pressure. We know that it works. 37% of patients who take a diuretic will reduce their blood pressure to normal. 45% of them will reduce their risk of cardiovascular disease and strokes. But we know that the uptake in Clinic A versus Clinic B, that differing kinds of patients may adhere differently to the therapy. Some of them may take them every day, some of them may take them intermittently or not at all. And then, of course, those factors that may be associated with improving the education so that people understand it better may improve. Now, where operations research and implementation science differ from dissemination, so not just putting diuretic therapy into a clinic, is that it answers the question how. How do you put the diuretic therapy into routine practice? What works and what doesn't work? Do you need a nurse to educate patients? So that may be one of the questions why, for instance, one clinic or one healthcare system, let's say in one oblast, will do much, much better than another one. It may be that the staffing is different, that the availability of pills is greater. And then, of course, I gave you the numbers of 37% of patients will normalize their blood pressure, but is that true in a real-world setting? Because most of those that come from randomized controlled trials, which is not operations research. That is kind of what we would call the evidence-based intervention. And so in a setting where patients may take a diuretic, but they continue to eat salt, or they don't exercise, they don't lose weight, that 37% may be reduced to 15 or 20%. And how does that happen and why is part of what we try to figure out with operations research. So I understand that each of you have heard presentations on what is an evidence-based intervention, but in order to provide some introduction for this particular presentation, I want to make sure that I define what an evidence-based intervention is. And what it is, it's a scientifically proven approach with repeated documented efficacy. So it's not just one randomized controlled trial, but it's typically something that's been repeated so that you've proven it at least twice, that it's unassailable, if you will. And it's usually proven through a randomized controlled trials. And so one of the examples, and I'm going to give you a little bit of information on this, is that we know that mother-to-child transmission using antiretroviral therapy is an evidence-based intervention. We know that from multiple trials and even systematic reviews that directly observed therapy for the treatment of tuberculosis is an evidence-based intervention. However, for instance, some people argue that the case of directly observed therapy with tuberculosis doesn't work, and it's the operations research and the implementation science that really help us understand a little bit better about how it works in one setting but not in another. Now, I think that I see that somebody is asking a question. That question is not translated for me, so I don't know if Irina or anyone wants to answer that question, or ask the question that's written in Russian. I'm trying to read it. It says, well, I can't. I'm sorry, I can't read Russian. I apologize. Um, so let's see what we have here. I guess I will keep going until I get that question translated for me. So let's talk a little bit about the sort of uh, the sort of methods that are used for operations research. First of all, the type of method that is not used is the randomized control trial. That's how we create the evidence-based intervention. What is typically used for operations research are what people have traditionally called less scientific, but it's truly not. It's, for instance, one might use what we call quasi-experimental methods. One such example is the sort of classical pre-post analysis. So in other words, you might look at the number of clinic visits that people have made over the last 6 months. You provide an intervention that is an evidence-based intervention and look to see whether the clinic appointments change in accordance with that intervention. Now, there are some limitations to this kind of research because we know that if there are changes in the way that that the clinic operates or the staffing, that can actually impact the sort of the analysis for that. We also know that there can be modeling strategies that's used for operations research, and this is a more sophisticated way to do this, and it's not for every single sort of clinic or system to use, and is oftentimes used more to help people at a much, much higher level within the whole health service system. So it is part of operations research, but it's at the more macro as opposed to the sort of micro level. One might also use qualitative methods such as focus groups or semi-structured surveys to get at how and why something is working or not working in a given setting. And in the case of quality improvement, it's really looking at the fidelity assessment, or how do people actually do what is recommended. For instance, we know that an evidence-based intervention to reduce transmission of infectious diseases within a hospital is simple hand washing. And that's in between every single patient. The recommendation is to wash before you go into a room and after you leave. But the fidelity of whether that's done is really quite poor. In fact, numerous operations research studies have actually watched physicians and nurses as they go into and out of each room. They're usually people that they don't even recognize that are watching them, and they actually count the number of times that that this is being done. And what they have found is that from an operations research perspective is that the fidelity, so the recommendation is there, people say that they do it, but the reality is that they don't. And so that's another sort of example of a method that is used with qualitative research. Now, what I'd like to do is I'd like to go back and examine an evidence-based intervention that we know that works to prevent mother-to-child transmission using antiretroviral therapy. And this particular slide really compares what happens, and this is across multiple studies in multiple regions of the world, but on average, if a pregnant woman with HIV does not have access to antiretroviral therapy, about 40% or so of their infants will become infected with HIV, and that number reduces dramatically with the use of antiretroviral therapy. And we know that there's several different types of approaches. It's a full complement of therapy, so combination therapy. We know that single dose nevirapine has been used. We know that AZT, and overall, there's about a 13% likelihood of a patient getting infected. But when a woman takes combination antiretroviral therapy and achieves viral suppression, that number is actually reduced to 1%. So there's some variability around that 12.6%. And operations research says, how is it different that in one group of women it's less than 1%, but in another group it is 25%, lower than with no antiretroviral therapy, but indeed different. So the first thing that one does when they are trying to look to see how the research is, or how the findings differ from country or from clinic, or even within your own oblast, is to really make sure that you do all of the basic reading. So understand the problem. And one of the things that we know is that mother-to-child transmission varies depending upon the site without antiretroviral therapy to 25 to 45%. So we know that there's some margin of error. Different studies, they have identified the sort of factors that are associated that increase the risk of HIV transmission to the baby. For instance, we know that when a woman delivers vaginally, and if her viral load is high, it markedly increases the likelihood of transmission to the baby. If she has advanced HIV, or if her viral load is high and her CD4 cell count is low, that increases the likelihood. So the viral burden is associated with transmission. If the labor is difficult, in other words, she has premature rupture of membranes, or the baby sits in the vaginal canal for a much longer period of time and is exposed to infected blood, that increases the likelihood of transmission to the baby. And then also, if she has a concomitant sexually transmitted infection such as gonorrhea, herpes, chlamydia, that will increase the likelihood of transmission. And then last, if she breastfeeds after delivery, it doesn't increase the risk during delivery, but it increases the risk in the post-delivery phase, but results in significantly high levels of transmission of HIV. So the question is how? So this is the operations research question. How do you improve these outcomes when there may be different findings? And so in order to do this, and these are the stages of where you begin to look for the reasons why differing clinics may have differing sorts of answers. And this is just an example, but it can be applied to hypertension screening. It can be applied to malaria prophylaxis in Africa. You can create the question, but the methods are somewhat similar, but you have to have the basic information. So first of all, in order to have the most optimal outcome, all pregnant women with HIV, or I should say all pregnant women, should be screened for HIV as early in their pregnancy as possible, so that you can monitor them and get them onto antiretroviral therapy and hopefully achieve viral suppression. Women should be initiated on combination antiretroviral therapy during the second trimester of her pregnancy, and that ideally the women should be tested to make sure that they don't have any sort of resistance to antiretroviral therapy, and they also should have a platform whereby they get assistance with adherence so that they take 100% of their medications. Now, there are going to be some women in some clinical settings who don't come into the maternity ward until it's time for delivery. So you also then need to have systems in place to do rapid testing. So, and that any woman who has a preliminary positive rapid test gets immediate antiretroviral therapy. We know that that will reduce the likelihood of transmission. And then, of course, we need to make sure that the women have the availability of formula so that they don't have to breastfeed, because that could increase the risk back to the baby, even if you do all of the other sorts of things correctly. So let's get back to the question of disentangling some of the issues around whether we're talking about operational research, implementation science, or health system delivery. And from a research perspective, we're really looking at, for operational research, those factors that are happening at the healthcare provider level. So those things that are happening kind of on the ground. Once you start moving on to implementation science, you still include some of the issues that are relevant to the healthcare providers and the healthcare sites, but you're beginning to look more organizationally at multiple sites and multiple places. And then, of course, it gets much, much bigger when you start looking at a healthcare system issue, because this is really like your minister of health or the policymaker, the head of your aid center, who has to make some decisions. And that's at the absolute broadest level. Now, this is a continuum, and so I want us to make sure that we recognize that it's a continuum of research, and many of the methods are the same, but the sort of message that you need and who you have to convince is going to differ depending upon whether you're looking operationally in the local setting, implementation as you're moving from the single clinic to multiple clinics, and to the healthcare system when you're looking at, for instance, financing and how that may actually impact outcome. In this next slide, you can see that I've tried to really break down the sorts of domains, whether it's operational research, implementation, or health service delivery, and who the focus is on, and who are the users of the findings, and what are the sorts of areas. And if the research focus is operational, it usually is about a specific healthcare program. Once you start getting into implementation, you're using the evidence-based intervention and looking at how it differs from clinic to clinic. And then that sort of system may ultimately go to the health system to say, all right, great, it works in 80% of our clinics. So the evidence-based intervention works in 80%, but it's going to eat up 90% of our budget. So people may have to make some relative decisions at that particular level, whereas a group of doctors from an operations research perspective might say that initiating diuretics for individuals that are hypertension, this makes sense for our clinic, and we can figure out how to get our nurses to screen everybody the minute they walk into the clinic. We can have them put a circle around an elevated blood pressure, and then the doctor is reminded that, for instance, he or she may need to start therapy. So this is the sort of organizational structure that we use as we begin to think of the differing but related kinds of research methods. Now, there are also conflicts, if you will, about how we use the sort of information. So, for instance, as a researcher, most researchers who are doing this, whether it's at the operations level or the implementation science level, are really able to do their work based upon an available supply of information. Whereas if you're at the health system level, you're really basing it on demand for usable knowledge. So you may have limited information, but you have to make a decision for the majority of people, but it may negatively impact individual sorts of clinics. The time frame by which we want to do things differs. Typically, let's say a health system may need to want the results immediately, whereas from a scientific perspective, we want fidelity, we want the perfect study, we want to make sure that we do it properly, we want to to do everything in a careful way before we say anything. So there's a real conflict between the people at the health system level versus the people who are doing the day-to-day operational research and implementation science. And so we have to recognize that this tension does exist. We may find that something works beautifully in our clinic setting, but the people who are funding us have no interest in this because it's perhaps an expensive therapy, but it's something that's really quite important for our own sort of unique area. And so people may allocate resources differently at the local level versus, let's say, at the health system level. So let's move on to operations research, and let me give a little bit of history about where it came from, because it was really never created initially to deal with medicine and healthcare delivery. It actually evolved first from engineering. In fact, it was probably 60 or 70 years ago during the war era, and it was done for engineering, actually to the assembly of airplanes. And so, in other words, if you automate the engine of the production of the airplane, you can actually improve the production of airplanes, because that particular component, that piece of the airline assembly, took the most time. So if you could automate that, that was the rate limiting factor, so that they knew that if they could increase their sort of resources to the creation of the engine in an automated fashion, they could crank out the airplanes much faster. And what operations research has then done is it's applied the same sort of methods and ideas to business and also to medicine. It says that if you have, for instance, the nurses check the blood pressure for everybody who comes into clinic, as opposed to waiting for the doctor who sees someone and they said, my head is hurting, and then they forget to do the blood pressure. So you automate blood pressure, if you will. You can actually increase the likelihood that they'll be prescribed a diuretic, and they'll reduce the negative consequences of hypertension. And so the idea of operations research is that it's supposed to provide a rational basis for decision making. So it says that if we do X, we can expect Y. And so it solves many of the complex problems about what you want to do in order to kind of improve efficiency, if you will. As I mentioned before, there's a number of different tools that are used. Many individuals use mathematical models or computer simulations to look at the sort of flow of individuals through systems, or the process by which you get individuals to wash hands in the hospital, such as reminders on doors, etc., to really assist in the decision making. Now, as it relates to healthcare, the operations research, as I pointed out earlier, will typically focus on a local problem that will take into account the particular context in which it occurs. For instance, Hospital A may have a lot of nurses and a lot of doctors and relatively few, maybe just the opposite. But the expected sort of delivery of patients, that is, you still have to see, let's say, 1,000 patients per month, is the same, and the staffing resources are differently. So how do you create some solutions to these operational problems within the healthcare clinic or the system? And what it really does is addresses the problems that really confront the delivery, so that you have useful answers or solutions that allows you to modify and change your practice. But with any sort of change in your practice, that is the why, you figured out that it's the why part that is the problem. And then once you make that change, you have to restudy it again to see if the changes that you made actually make a difference. Now, implementation science is broader. So it now really requires that the evidence-based intervention has now got to be rolled out, if you will. Rolling out antiretroviral therapy to all people with HIV whose CD4 count is less than 350. We know that that works. It's an evidence-based intervention. But we know that the uptake may differ from site to site. Individuals may be reluctant to start antiretroviral therapy. The clinicians, the doctors, may be reluctant. They may not feel as though they have the skill set. They may feel as though it's too safe. There may be local and traditional beliefs, health beliefs, that interfere with the ability to do so. So it really helps us understand why it's working in one place and not in another, and what are the sorts of things that one has to do in order to improve it across the different system. Now, on the next slide, there's a number of research questions, and it's very important to create a research question for you so that you can begin to design your sort of study. How do you answer your question in an organized sort of way? So, for instance, we're going to spend a little bit of time with this, but do phone call reminders result in people being retained in care? So that's an important question, and I'm going to try to go through a good example of that in a few moments. Which clinic model, in other words, a polyclinic or a specialty clinic, results in the highest percentage of HIV-positive patients, achieving viral suppression? A polyclinic may be less stigmatizing, so many more people may go there, but maybe perhaps the care isn't quite as specialized, so the outcome isn't as good. But if you have 1,000 patients who get onto therapy and 50% achieve viral suppression, that's actually better than having 75%, or I should say 500 patients get onto therapy and 75% achieve viral suppression. So the magnitude of the number is actually greater in the polyclinic, but it's contrary to what a person might think. The implementation science issues are, for instance, might be, how do you implement routine HIV testing in emergency departments? And one of the sort of recommendations that we got from our government was that we should do this in every emergency setting. Well, the truth is that it differed so dramatically differently from site to site, because one emergency room system may have been overly crowded, and they were really dealing with whether people had traumatic brain injuries, heart attacks, etc. And doing an HIV test was the least important thing to do. So there may be some very big differences between how something gets applied, despite the fact that the evidence shows that you can actually reduce HIV transmission by identifying them. An example, that is identifying a person with HIV. From a health system perspective, one of the things that is coming to bear is, for instance, have these electronic health records improve the health care of patients in Europe. And it's the idea that a patient may have multiple providers. They may go to see the liver doctor for their hepatitis C. They may go to the TB doctor for their TB, and they may go to the HIV doctor for their HIV. And the electronic healthcare record may actually improve the sort of communication, because everybody can read each other's notes, as opposed to picking up a phone call or relying upon patient history. And so the question is HIV, the tuberculosis, and the hepatitis C. So there is sometimes some confusion about what operations research is and monitoring and evaluation, and it is absolutely critical to understand that they are truly not the same. The objectives overall are somewhat similar, and they really want to understand what's working. In other words, are you getting a lot of people onto a diuretic therapy if they're hypertensive and not working well, and why? But the monitoring just gives you absolute numbers. It says that of the 100 people screened, 50% had an elevated blood pressure, and 45 out of those 50, so 90%, started therapy. But that doesn't tell you why, because if you look at the next clinic, it may be that 100% of them are screened, 100% of them are put on diuretic therapy, but none of them achieve a normal blood pressure because nobody takes the medications. So the operations research helps you understand why you have these differences from site to site. And so it's the how and the why, and using scientific methods that distinguishes monitoring and evaluation, which is just numbers, to the processes or the operations of what you're doing. So as I pointed out, that there may be differing kinds of skills that are required. Oftentimes when my team is doing operations research, I bring in experts from multiple different disciplines, such as decision analysis, health services and outcomes research, epidemiology and statistics, finance. Sometimes cost effectiveness is absolutely critical. Behavioral sciences, qualitative researchers, medical anthropologists, and even in some cases ethics, because one might recommend an intervention, but let's say it's contrary to a religious belief. And can a health system impose a problem or an intervention in a group of individuals for whom it doesn't work in their sort of cultural context? So all of those could be sort of explanatory. So let's talk about the steps necessary to operational research project. The first thing that you need to do is identify that it's a problem. And each of these steps I'm going to try to go through in a little bit more detail. But once you identify the problem, you have to formulate a plan. You have to decide that you have to have a scientific way for trying to figure out that that you can assess this problem in a reasonable sort of way. You have to decide before you ever start the project, what is the outcome that you want to measure? In other words, do you want to measure that 100% of the patients in a clinic get screened for hypertension, or do you want to measure that the ones who do have hypertension are more likely to, or are actually going to receive a diuretic therapy? Once you decide what the outcome is, you have to decide on the methodology. Do you use systems research? Do you use mathematical modeling? Do you use qualitative methods? Do you use a quasi-experimental sort of approach, or do you use a combination? Next week, I'm going to present some data looking at how you may have to use multiple methods in order to answer your operations research problem. Then you have to implement the intervention. So what is the evidence-based intervention that you're going to use? So you have to do that. And then you have to reassess and modify the implementation, because you may find that you chose to have nurses do all of the screening for high blood pressure. But indeed, they were so busy that they never did it. And so even though you set up the implementation and you train them, the reality was the fidelity to the recommendation didn't happen. And so there was no improved outcome. So all of those are the factors that have to go into the sort of research design. So the first step, let's identify the research question. And in general, I suggest that you just use good common sense and that you just make an observation. So if you happen to be the doctor or the administrator of the clinic and you see that your patients just aren't coming in for their follow-up visits, or that's your impression. It may be true or it may not be true, but you begin to start answering the question. You say, aha, there's a problem here. Let me see if I can figure out what's going on. So the first thing you do as you're sort of identifying the research question is you're really deciding, is your research question and your observation, or I should say, is your observation accurate? So what you might do, as an example, is you might review the clinic schedule to determine the frequency and the proportion of patients that don't return. Let me give you an example. If you happen to have an HIV clinic and you have registered within your HIV clinic 1,000 patients, um, well, we know that the recommendation for monitoring them is to have a CD4 cell count monitored every 3 months. That's the sort of national, well, let's just assume that that's your national recommendation, but in most places in the world, that's pretty accurate. So if you did the simple math and you said, okay, I have 1,000 patients, and if everybody shows up to clinic every 3 months and gets their CD4 count monitored, that should result in 4,000 CD4 visits or clinic visits as well. But what you recognize as your sort of observation is that you go to your laboratory and say, okay, in the last 12 months, how many CD4 tests were done? But it's only 25. So you're well below what you're hoping. So your original observation is accurate. Patients are not getting what I operational strategies to do this. This is just one example, and there's a dozen of really good models, but pick any model you want. And this one's a very easy one. It's called Plan, Do, Study, Act, and then introduce the intervention and study it again to see if the processes, or the operations, if you will, are holding true when you make a change. So the next step is to kind of set your goals and objectives. And you've already now decided, okay, I have a problem in my clinic. Now I want to determine the reasons why. So it's the why question. There's a difference between the expected number and the real number of CD4 count monitoring. So the first thing I want to do is I want to use my own common sense, but my common sense may not be enough. I may have to get the advice or the expertise from other colleagues in the field and from patients themselves. So the ways that I may get information is I may pull together all the doctors in my clinic and say, what is your sense of why your patients don't show up or why they don't get their CD4 cell counts? Is it that you forget to give them a slip, a laboratory slip to go to the laboratory to get their blood work drawn? Or is it that they just don't even show back up? Or is it that the patients come in and they get annoyed and storm out? Or that they're very difficult and you can't have a relationship with them. So you may do focus groups with the sort of professionals, but in many cases, the professionals are going to come into this with the same sort of biased ideas that you do. So here's where the science comes in. So you have to actually perhaps get additional information through, one way would be qualitative research methods. You could pull together a group of patients who show up every 3 months, just like clockwork, and say, how is it that you're able to get to clinic every 3 months and do such a perfect job, managing your HIV? But I would also get a group of individuals who come one time a year and bring them into a group and say, okay, you're supposed to be here about every 3 months, but that doesn't really happen. What are the sorts of things that get in the way of you being able to come back for your sort of treatment? And the sort of findings that you may have may be really quite broad. Or you could actually do a focus group and then follow that up with a survey, a standardized survey where you actually make a list of all the options and ask patients to rank them or to say what is most important or what is least important. Once you do that, you have to define. Sort of observation was that patients don't come back regularly for their look at this. One of them is you could really assess the number of clinic visits that the patient makes. But there are some limitations by doing that. Or alternatively, you could say, well, maybe I should really look at whether they're actually getting a CD4 cell count. That's a more objective measure because they actually get something done. So let me give you an example of where using the number of clinic visits could be a serious problem with your sort of operations research methodology. So as we said before, if you had healthy patients, and you have 1,000 of them in the clinic, and you expect them to come in every 3 months or 4 times a year, that would be 4,000 patient visits per year to the clinic. So that's your sort of expected sort of outcome if you use clinic visits as your marker. But what if in reality you've got 1,000 patients and they make 6,000 visits per year? And you go, maybe perhaps they're overutilizing the services. But that may not indeed be true. When you actually go back and look at the numbers, this monitoring and evaluation part, you may find that there's 750 patients, but they make 6 visits per year. But the reason why they make more than the recommended 4 is because they're sick. They come in, they have side effects from their medications, they have opportunistic infections, they're feeling sick, they're afraid that they're going to die, they're psychologically distressed. So what you may find is that if you use a marker like clinic visits, you may actually not measure what you're looking for, and that is that patients actually come in routinely because you may have a minority of your patients making the majority of visits. So let's go to the use of CD4 monitoring as a marker because we have clear recommendations for how often that should be. So irrespective of whether a person is sick every week of the year and they come in to see the doctor, they make 52 visits per year, you would at least expect a CD4 cell count to be done 4 times. So your sort of outcome would be 4,000 measurements. Now, how could that possibly underrepresent the true number of needed visits? And that is, let's say, for instance, if you happen to be in a facility where your CD4 machine is broken 4 months out of the year. Patients come in, they get seen, a doctor would love to order a CD4 cell test, but there's no technology available. So you have to understand your system and before you make a decision about what is the sort of desired outcome that you want to make. So you first of all plan your sort of research strategy. You may have focus groups with patients, with doctors, and some of the things that the patients tell you is that the reason why they don't come back is that, you know, it's really difficult to get to the clinic. It's 50 kilometers for me to travel, and that's just too hard to take a day off from work in order to do that. Or they may have come to the clinic, and because they were mistreated, that somebody said something not very nice to them, and they said, I don't want to come back. They came and saw the doctor. The doctor recommended a CD4 monitoring, but they didn't really understand that they had to go to a laboratory which was on a different building in the compound. In some healthcare settings, it may be that they can come see a doctor and they can afford to pay that, but the laboratory test costs money, so they might have to pay for that. Once you do that, you then need to pilot it, whatever it is that you're going to do with some kind of assessment, to maybe quantify what are the most common reasons. Because if you're going to do an intervention, you're going to try to improve your patient's sort of showing up for CD4 monitoring. You want to choose the one that's going to have the biggest impact. This is the operations sort of component, to have the most impact for the least amount of sort of work. So, you know, as I said before, you have to make sure that you sample the right patients, those in care and out of care, in order to get an objective measurement, because if you only measure those patients who come in every 3 months, they're perfect patients. They're not going to have any complaints. They're going to think that the clinic is perfect. But the patients who don't come in are the ones that you really want to speak to. So on this next slide, I have sort of documented here the patients who are or the bars that are in red are the patients who don't return 4 times per year, and the ones in green do return. And so from our focus groups, we decided that we would assess the 5 most important reasons why that or challenges that patients had to come in and get their CD4 cell count monitored every 3 months. And the 2 most reasons for why they don't show up happened to be related to that they just forgot their medical appointment or it was too far to come. And then you begin to differentiate if there's a real difference between whether it's in the patients who do and don't return. And by doing this initial sort of operations research assessment here, you're now beginning to understand why. Why is it that patients are not coming? And forgetting is the most common reason. And it's most common among the ones who don't show up on a regular basis. And so you say, now I need to come up with an intervention that is going to help improve people's memory. Now, we can't do a brain transplant, but we can come up with some ways to remind patients. So we have to come up either from a review of the literature or talking to experts in the field to choose something that we know that works and that it's something that everybody is in agreement that they're willing to try. So you make a list of the sort of interventions that you want to try, and they're all in the category of reminders. And so, for instance, you might have phone call reminders to confirm an appointment. Who does this? Is it the receptionist? Is it the nurse? Is it the doctor who does it? Those are all processes that are part of operations research that you have to figure out in terms of who does it. Do you want, or you may decide that's too much work. Calling people is too intrusive. I really don't have time to do that. So what you might do is you might create an appointment card, a card that patients find that's very important to keep. And each time you write it on that card and you have them put it in the wallet, but they still might forget. So the likelihood of that working, doesn't work as well. But it does work in resource poor settings like in sub-Saharan Africa because those pieces of paper are very valuable. But in middle income and high income countries, people just toss out pieces of paper because they have all of these electronic gadgets, and that's how they keep their information. You could decide that you would send mail, an email or a regular letter a week or 2 before the appointment to say, by the way, you have an appointment next Tuesday at 3 p.m. to see the doctor. Or you could use a very expensive intervention for very difficult patients where you get a community outreach worker to go find the person in the community. And you may decide that that's too expensive, but it may be the most important for the individuals who have the worst outcomes. So now let's go into the operations and implementation. So first of all, in order to know that your intervention is going to work, these phone call reminders, you have to be sure that your patient has a cell phone and that the number that you have is correct. So you need to test to see whether you can actually reach them. You have to ask them, is it acceptable for us to call you on your phone to give you a reminder? Some people don't like to be bothered with phone calls in the middle of their workday. You might need to create a system where the receptionist would get a list of all the patients 1 or 2 days beforehand, so he or she could pick up the telephone in between other patients and call them, make notes. Did they reach them? Did they not reach them? Was the number disconnected? So you need a way to measure the sort of process of how the receptionist does it. You probably need to do that by creating a phone call log to see whether the person was called, how many times they were called, did they reach the patient, did the patient say that they could make it or not. So that would be an example of a phone call log. But then the next important thing is that the staff member who's going to be doing this has to be trained on how to do it. And they need to be pilot tested. They need to be observed to make sure that the fidelity of what they're doing is exactly the way you want it to work. For instance, if you say, all right, here's a list of people, give them a call, and tell us whether or not you got hold of them. Well, The receptionist might say, oh, I might lose my job if I don't call. I'm too busy. I'll check off that I called everybody, but the patients don't show up. So the sort of fidelity part of the process is already damaged by that. So you actually have to watch the person in some cases. And I'm just giving examples for this. Then you have to have a research strategy once you've created the sort of intervention. And the research strategy for this particular thing might be a quasi-experimental design. You take a look at the number of CD4 tests that were done in the last year. You give yourself some pilot time, and then you take a look and you see whether the CD4 tests are done properly for the next year. So it's a pre-post evaluation. Now you need to make sure that the CD4 count machine didn't break down, that the staff who runs it, the test, didn't disappear for a 3-month vacation. So there's all of those things that can actually jeopardize a pre-post analysis. But you definitely want to do this, and you want to also make sure that you're keeping a record of all of those process measures, such as the phone logs, and listen to how the receptionist interacts with the patients. If the receptionist is rude, the patient's not going to show up. So here's an example of a way to look at this. So on the left-hand side, you could potentially get 2 outcomes, and now you have to explain why, or how did it happen that you get 2 different findings from 2 different HIV clinics. Outcome 1 is Clinic A, and outcome 2 is Clinic B. And what you see is that by instituting the receptionist calling the patient a few days before their appointment, that you increase the number of CD4 tests from 2,500 to 4,000. So you have had a huge, a 60% increase in the patients who actually get continued in care. But in Clinic B, or Outcome 2, you find that there's really only a marginal increase from 2,500 to 28, which is essentially no different whatsoever. So the question is, why didn't it work in Clinic B, but it did work in Clinic A? So you have to now begin to answer the question, and some of the answers may be in your phone log or in your fidelity observation. So let me give you an example. So you begin to review all the possible explanations for why the operations worked in one but didn't work in the other. You may find that the receptionist was really busy and they only called 2 days per week, or the receptionist just didn't want to, didn't like talking to patients, but they're willing to fill out paperwork, or they didn't get the information from the scheduler 2 or 3 days in advance in order to, in order to make that phone call. So there was a process or an operation which didn't happen correctly. What if you happen to see that the phone log showed, according to the receptionist, that everybody was called? Well, it's possible that the explanation is that the receptionist actually really didn't call. They just put a check mark and said, we did it, but in reality, it didn't get done. And unless you have someone who's watching privately, 1 or 2 days per week, you don't know whether those sort of recordings are accurate. It may not work because you happen to be in a place where everybody changes their cell phone number every month. And so by the time that you have a proper cell phone number, 3 months later, when you want to remind them, their phone isn't working and you can't get a hold of them. Or you might be in a place where people just don't have phones. They may be too poor to own them, or they share phones and they don't want other people to get their phone calls. Or you may find that patients didn't really pick up the phone and didn't get the message because they prefer texting because of confidentiality reasons. So these are all reasons why you have to go back and reassess the sort of operations that either worked or didn't work between each clinic. So you planned your study, you implemented the protocol for the receptionist to call the folks. You studied it, you found it worked in Clinic A but didn't in Clinic B. and now you have to do something. So you now have to go back to Clinic B and refigure out how to do this properly. It may be that the scheduler just didn't create the list, and so you need to create a more automatic system for doing that, and then reassess them to see if they achieve parity with the other clinic. So in summary, and I know that we're at the end of our hour, and I want to give everybody time to ask some questions, is that operational and implementation science research does not tell if an intervention works, but how it works, why it works, and what are the various different pieces of the intervention that are working and not working from site to site. It provides either a scientific method or a series of methods or a group of methods to determine that whatever we think is an evidence-based intervention is going to be effective and work in the real world. We certainly know in the case of directly observed therapy for TB, it worked in every clinical trial, but in India, it didn't work because the DOT sites were so far away from where anyone lived that they couldn't get to the DOT site in order to take their medications, and so they just defaulted on their TB therapy. And I just want to say that you could tell from the sort of various different definitions that different people use that this is even though it's been around for a long time, it's a new group of evolving and interdisciplinary approaches that are really designed to improve your processes and your decision making so that you can optimize the health of your patients. And if you use these sort of techniques in a scientific way, the likelihood of improving the performance at the local area across a number of different sites and within an entire health system is likely to be improved. That's my last slide. Spasiba for sticking around and listening. And what I will do is I will open up the sort of question and answer period so that if you have any sort of questions that you want to ask, that you can actually type them out. Hopefully somebody will translate them for me, and I'll try to answer them back. Thank you. Spasiba. Somebody just commented, thank you, it was great. But I also would like to be able to answer specific questions that you may have related to this. Next week, I'm going to use a more concrete example, in fact, a real example that we've been dealing with here in Ukraine. So that may help. Okay, so it looks like that there are no questions. Thank you very much. And I will see you actually not next week.